right. So today we will speak about neurostimulation for migraines. Um, and this is a brief outline. First, we'll talk about peripheral nerve stimulation, including devices like Cefaly, Nerivio, electroacupuncture, implanted peripheral nerve stimulators, vagus nerve stimulation, transcranial magnetic stimulation, and some things we will not have time to talk about. They are less practical for most people, and those are transcranial direct current stimulation, TDCS, which is not just, it may be practical, but there is not much evidence for migraines. Deep brain stimulation, which is an extreme procedure where they drill a hole in your skull and put an electrode deep into the brain, which is also not very practical, obviously. And then there is a new technology called focused ultrasound, where the ultrasound goes through the skull without having to drill a hole and stimulates different parts of the brain. But it's very early in development, so we're not going to cover that either. So Cefaly is it's been around for a couple of decades, and it's a device that stimulates peripheral nerves around the forehead. Usually these nerves we call supraorbital, trochlear nerve. But there are some cheap imitators now. I don't know how good they are, but by looking on the internet, I found some cheaper version of the same kind of a device. Again, I would recommend sticking with the Cefaly just because it's been tested in clinical trials, and I'll show you some of those trials. And fortunately, the manufacturer of Cefaly gives you, I think, a month or two of free trial. So if you don't find it helpful, you can always ship it back. So Cefaly, again, it's been around for a while, and this is one of the first trials published in journal Neurology, which is the leading neurology journal. And it was very well conducted and rigorous scientific study comparing real stimulation with so-called sham stimulation. People thought they were getting this electric stimulation, but they were just feeling something, but not quite the same as the real stimulation. And the primary outcome measure was the change in monthly migraine days, and also 50% responder rate. That is, how many people had at least 50% improvement in their migraines. So there were 67 patients in this trial, and by the third month of treatment, mean migraine days decreased significantly in the real group. There was about 7 fewer migraine days, and in the sham group, there were only 6. Again, in the real group was 7 versus 4.8. In the sham group, it was 6.5 versus 6.22. That is a significant difference in the groups. In monthly migraine attacks, headache days, acute anti-migraine drug intake was reduced, and there were no side effects, which is no surprise. It's a very benign treatment. And then there were also a follow-up study, several studies. This was published in the Journal of Headache and Pain, showing that 2,300 headache sufferers who rented the device for 40-day trial period found it to be effective. Here's the data on that. After, on average, 58 days, 46%, 47% of those renters were not satisfied. And the compliance check, they used it only for 48% of the recommended time, and 54% were satisfied and were willing to purchase the device. My overall impression from clinical practice is that half of the people who try Cefaly, and the same applies to the other device we'll talk about, Nerivio, were willing to continue the treatment. There was 99 people, 4% reported some side effects. None of them were serious. And the side effects that I see in Cefaly, as some people say, makes my headache worse. People who have what we call allodynia, or increased sensitivity of the skull to touch. People have trouble wearing glasses or earrings. Those people really don't like putting devices on their forehead. So that side effect was, again, irritation, worsening of the headache, so people take it right off and don't use it again. Sometimes people were also sensitive to the adhesive. You have to stick an electrode on your forehead and then attach the device with magnetic attachment. So some people find skin irritation from that. So those are the only minor side effects that were reported. Some people feel fatigued, but it's very, very infrequent. Nerivio I find to be a bit more practical because you can appear on a Zoom call and the device is on your arm rather than on your forehead, where you look like a space alien with Cefaly. So Nerivio was also subjected to rigorous clinical trials, both in acute and preventive setting. And by the way, Cefaly was also tested for prevention of migraines. So if you put on Cefaly for 20 minutes every day, seems to reduce the frequency of migraines. Most people use it acutely. That is, headache begins, you put it on, and you feel that the pain subsides. Again, not always completely, both for Cefaly and Nerivio, but some patients actually combine the device with the pill. They take a pill, and if that doesn't completely eliminate it, they often use a device alongside the medication. And for some people, it works alone as well. So Nerivio stimulates the peripheral nerves in the arm. And many people are really incredulous. Why would that help my headache if I put it on my arm? Well, it's partly due to the so-called gate theory of pain. When you bruise yourself, it feels good to rub your bruised area because when you do that, you stimulate large, we call it myelinated fibers that conduct touch sensation very quickly to the brain. Pain is transmitted to small fibers called C fibers, and that takes a little longer for the pain messages to reach the brain. So when you stimulate the large fibers, they sort of close the gate in the brain, and there's not enough space for the pain messages to go up because the other large fibers are transmitting information and blocking this pain. So that's the simplified theory of why stimulating your arm will reduce migraines and stop migraines. So Nerivio has been tested, again, not just for adults, but also in adolescents, both for acute and prophylactic therapy. This is the study you see on the left circle is adults, and the right circle is adolescents. And the results were very similar. And it not surprisingly, when you use the device and if it's effective, you will be taking less medications, which is a obviously good thing. You avoid the side effects of medications. And again, like both prevention and acute therapy are effective. And for prevention, it's sufficient to put it on every other day, at least according to this study. People were using it for 40 minutes every other day. Now, there's no limit to the use of Nerivio or Cefaly. You can keep it on for as long as you like. The only issue is with Cefaly, the pricing, I don't know whether it's going to be in Ireland or in Europe in general. In the US, Cefaly is a device you purchase and you own it. But again, the trial period makes it worthwhile trying it so you know if it's worth spending the money. Nerivio is a different kind of a device. It's a disposable device. Each device that you receive is good for 18 treatments. And then when that battery runs out, you throw it away and buy a new one. So and there is an app that you use to control the device. And because there is an app, and that's when you order refills, order subsequent devices, we know good numbers. And specifically my patients, 50% of them order another device. So they keep reordering. So just like with Cefaly, half of the patients find it helpful, half do not. I know you have a lecture coming up by Mark Golding about acupuncture, but a few words about electroacupuncture. I'm a certified acupuncturist in the US. Um, Surprisingly, in the United States, you have to have a separate license. Even if you're an MD, you have to spend hours, hundreds of hours, uh, studying acupuncture before you issue the license. So acupuncture is, I should say, quite effective, even though many doctors, mainstream doctors, are very skeptical about its efficacy. They often think it's all placebo effect. But in fact, animal studies, the most convincing studies that tell us that it's not just a placebo effect. Veterinarians use acupuncture for small and large animals like dogs and horses. So there are studies I just listed here that indicate there are objective, definite changes occurring in various parts of the nervous system. So these are animal studies. And then there have been many trials in humans, but the problem with human trials is that just sticking a needle has a major placebo effect, which we have to admit that just the procedure and have someone having touching you. So it's very hard to study it objectively, like with electrical stim devices, you have a sham group. With acupuncture, people have been very clever in how they try to mask whether you get acupuncture or not. Some people just feel a tap, and there is a device that looks like an acupuncture needle with a cone on it. So you don't know if you really got the needle in. So people go to all kinds of extents to mask the sham trial and to have objective comparison. But nevertheless, these are very difficult trials to conduct to make sure the patient doesn't know if they're receiving real or not. So in 1999, Cefaly published a review of 14 trials, and there have been literally hundreds of trials of acupuncture. And the trend in those 14 trials was in favor of acupuncture, true acupuncture versus sham. And this was a very large study done in Germany. German health service covers acupuncture, so they decided to do a large scale study of acupuncture for migraines. And 15,000 patients. It was an open trial. It was not blinded trial. At least the largest part of it was unblinded. And of course, there was also selection bias. People were offered to be in a trial, blind trial. Majority of patients, of course, wanted to get real acupuncture. So those people probably have more of a placebo effect because they expected to help them, and that's why they wanted the real treatment. So looking at those large numbers, they found that there was a significant difference in quality of life in headache days per month in two acupuncture groups as opposed to control group. The drop was from 8.4 before the treatment down to 4.7 after the treatment, and control group was 8.1 down to 7.5. So an improvement persisted for subsequent 3 months. And that highlights one of the limitations of acupuncture that I find in my practice as well. And that is acupuncture often works and works well for some people, but unless you really address the underlying contributing factors and triggers, the headaches might return, migraines may come back, so you have to keep going for acupuncture treatment. And usually I recommend at least once a week, ideally even more often if you can afford it at time and money wise. In the US also, acupuncture is not covered by insurance unless it's done as part of physical therapy program. So I don't often do it because it is a lot of cheaper for patients to go to an acupuncturist like Mark Golding, who will be speaking. He's an acupuncturist rather than MD. MDs tend to charge more for the treatment. So I rarely do it. I usually refer patients to several acupuncturists that I know who are good, and people can afford to go much more frequently. So there was an editorial accompanying that large German study by Hans Christoph Diener, who is one of the leading headache researchers in Germany, in Essen. And he concluded that acupuncture is as effective as drug therapy, but sham acupuncture is also as effective as real. So it was hard to separate sham acupuncture versus real. Nevertheless, it was as good as drug therapy. And he also concluded that acupuncture should be offered to patients who do not respond to prophylactic treatment with drugs, terminate drug treatment because of side effects, or have contraindication to drug treatment. I'm not sure I totally agree with this. Why should we offer acupuncture to people who don't respond to drugs when acupuncture is much safer than drugs? It is true that acupuncture is costly and time consuming, but drugs tend to have more side effects and could have more issues with that. Interestingly, the German government that sponsored this trial in the end decided not to offer this as a covered benefit just because of the numbers. As we know, migraine affects 12% of the population. So it's very large numbers of people would qualify, and then that would be very expensive for the government to cover acupuncture for headaches. And one more type of peripheral nerve stimulation. So all these things we talked about is stimulating peripheral nerves, whether it's with Cefaly device, or supraorbital and trochlear nerves, or Nerivio, or electroacupuncture. And that, by the way, electroacupuncture is the same acupuncture, just a regular acupuncture. You just put clips that lead to a device that produces electric current. Um, and some people also asking me about the first two devices, Cefaly and Nerivio, whether they're similar to TENS, transcutaneous electric nerve stimulation, that you can stick on the skin, and physical therapists or physiatrists often use that to treat musculoskeletal problems. So the answer is yes, that's very similar to the TENS machines, except that both companies claim that their pattern of stimulation is unique and very specific and better than you would get from regular TENS machines. And it's true that TENS machines comes with a couple of knobs that allow you to change the frequency and the duration and the strength of the stimulus. But theoretically, you could stick on two electrodes from a cheap TENS unit, and on Amazon, you can buy one for like $40 and experiment with that, like put it on your arm. But it takes a lot of experimentation. It's not as convenient or proven. So, but it is in fact peripheral nerve stimulation through the skin or with acupuncture through the acupuncture needle. And there have been studies that used implantable electrodes. Here you see occipital nerve stimulator implanted. So you see two paddles on each side. First, they tried to put just the wires in, but wires always would slip out. So they devised this more secure paddle-like electrode that's inserted under the skin surgically, and it goes under the skin to a device like a pacemaker. And I've had patients who had not just occipital nerve stimulators. I had one patient who had also a stimulator inserted, implanted under the skin of the forehead or temples. Unfortunately, we don't have good enough data. Again, just like with acupuncture, very hard to do sham controlled trials. It is much more expensive. It's invasive, can cause potential infection. So that has not gone very far. Very few people actually use this, even though there might be some value to some patients, especially with occipital neuralgia. Next is vagus nerve stimulation. In the US, it's been approved for more than 2 decades for treatment-resistant depression and epilepsy. Now, we still don't understand why stimulating a nerve in the neck, and that vagus nerve is responsible for innervating all of your internal organs like lungs and heart and stomach and liver and kidneys. Then why would that help depression or epilepsy? Never. So we do have data that it works. And over 20 years ago, when I looked at this data, I was at a conference where they spoke about using this device for epilepsy. And I noticed that people who had real treatment versus sham treatment had fewer headaches. So, and running a headache clinic, we often have patients who've failed to respond to many, many different treatments. So I had 6 patients implanted with this device that was, again, FDA approved for depression and epilepsy. And luckily, I was able to get insurance to cover it because you never know, you could have what we call subclinical epilepsy that could result in headaches. Epileptic seizures, well known to cause headaches as well. There's a big overlap between epilepsy and migraines, and that's why we use epilepsy drugs to treat migraines. So for very refractory chronic migraine patients who failed drugs, Botox, and other treatments, and 2 chronic cluster patients. And cluster patients, cluster headaches are much worse than migraines. Some people call them suicide headaches. So cluster patients, both cluster patients responded. Their life certainly improved dramatically. And 2 out of 4 migraine patients responded. So the device is implanted, again, around the nerve. And there is a device implanted in the skin that has a battery that stimulates that nerve constantly. So that worked, and somebody read my paper that was published in 2005, 20 years ago now, and they developed a device that you just hold to your neck rather than having surgically implanted. And this device is called GammaCore, and they studied it both for migraine headaches, cluster headaches, for acute treatment, for preventive treatment. And as you see on this slide, patients did respond better than people who did not have this treatment, who had sham. So at 2 hours, 46 out of 79 headache patients responded, and pain was completely gone in 28%. So that looked very impressive. And the device was approved again by the FDA, but insurance companies in the US do not like covering devices in general. It was very fairly expensive device. You could only rent it on a monthly basis and pay a monthly fee. So I was actually even reluctant to offer patients because if it worked, they would be faced with a very, very high monthly cost. So the company then developed a device that has no medical indication, very similar, and they would sell it for less money. It's called True Vaga. So you can use that device and see if it works. Now, the difference between my published series of 6 patients and this is that the implantable device is always on. The patient can turn it off temporarily with a magnet, but this device you put on throughout the day or twice a day as a preventive treatment, and you get a few minutes of stimulation. So it seems to help, but it's not the same efficacy in my experience as the implantable device. But implantable device, again, is expensive and does have risk of infections and other side effects. But there are cheaper versions, and there is more. There are several companies selling devices that have no scientific backing, and the vagus nerve does have a branch that goes into your ear, and putting that device into your ear and having electric stimulation of that seems to produce some kind of effect. We don't know what the effect is and whether it does help headaches, but these are very popular, more than just these two vagus nerve devices, but they're very inexpensive. So if somebody wants to try it, there's nothing wrong with that. There is another device that's made in Lithuania called Pulsetto that simulates both sides at the same time. And they advertise it mostly for sleep. It helps in insomnia, but it might work for headaches as well. We don't know. I think the company may be planning to do some clinical trials for migraines as well. And just in July, 2 months ago, the FDA in the US approved another implantable vagus nerve stimulation device called set point therapy. And you see it on the screen, and that has everything in it, including the battery. So it's implanted in the neck. You don't need to have these additional wires and the battery separately implanted. And surprisingly, it's approved for rheumatoid arthritis because we know that stimulating vagus nerve also affects your immune system, reduces inflammation, it has many, many other benefits. So this same company is working on other indications as well, not migraines as far as I know, but they're looking at getting approval for this device for other conditions as well. And I think they're not selling it yet, so I don't know what the price is, but they're claiming that the price will be much more affordable than the old implantable devices, and the implantation procedure will be a lot simpler. So that's something promising, and hopefully they will also do migraine trials, and maybe eventually the medical authorities, the European Medicine Agency and the American FDA will approve it for migraines as well, or cluster headaches would be also nice. Now, TMS, transcranial magnetic stimulation, that has been also around for a little while. When I was a resident in training more than 30 years ago, my Department of Neurology at State University of New York Downstate Medical Center, they were doing all the original studies on stimulating the brain with magnetic coils. And that has given us a lot of interesting information about the function of the brain, stimulating magnetically. and also practically devices that are actually approved for the treatment of various conditions. And this device was approved by the FDA for the treatment of migraine, both in adolescents and adults, and both for acute and preventive treatment of migraine. So it's called eNeuro device, and it's pretty bulky, as you see, and has a big battery there that generates a magnetic stimulus, and you apply it to the back of your head, as you see it on this slide. So you press the button, it charges up the capacitor there, and then you press the button and you give yourself these pulses to the occipital lobe. And people who have migraine with aura would definitely know that that process involves occipital lobe of the brain, and maybe even other types of migraine also involve the activation of the occipital lobes. First, it was tested in people who have migraine with aura only, but then it was shown to be effective for people who have migraine without aura as well, which is the majority of patients. So you apply this 3 times, 3 pulses, up to 3 times for each attack when it happens, or preventive daily treatment, 4 pulses twice a day. So it's a very small amount. And it still seems to be effective for some people. Again, this company was in and out of business for a while because, again, the cost was considerable and the insurance companies wouldn't cover it in the US. So it's back on the market in the US. And these are some of the studies that led the FDA to approve it. The first one was published in 2010. And again, single pulse transcranial magnetic stimulation for acute treatment of migraine with aura. So with aura was first, and then they published other studies, observational studies, and control studies as well, looking at treatment of migraines in adults and adolescents, and even in difficult to treat migraines. So those are just like with the vagus nerve stimulation, you got a few pulses, few minutes of stimulation versus implantable where it's always on. Single pulse is nice, but when you use repetitive transcranial magnetic stimulation, which is a totally different device, and I'll show you what it looks like, you get thousands of these impulses rather than just a couple of dozen. So FDA approved the repetitive transcranial magnetic stimulation for major depressive disorder in adults not responsive to at least one antidepressant. And I think now they also approved it for children as well. OCD in adults, if treatment resistant, has an approval from the FDA. And also some devices were approved for smoking cessation. So that's very interesting. And also for peripheral nerve pain. You apply that magnetic stimulation to peripheral arms, legs, wherever the pain is. So this is an outpatient procedure. Patient is awake. There's no anesthesia required. There's magnetic coil placed on the scalp, and it delivers focused magnetic pulses to stimulate specific brain regions. For depression, anxiety, left dorsolateral prefrontal cortex, which is left front of your head. Typical session is 15 to 40 minutes. The official protocol approved for depression is 5 days a week for 6 weeks, 30 sessions. Side effects are mild. And there is an accelerated form of TMS developed by Nolan Williams at Stanford, where people who are severely depressed and suicidal, who are in the hospital on suicide watch, doing 10 short sessions of this treatment, average time to discharge for these patients were 3.5 days they left the hospital. So that's very promising for severe patients with severe depression. Migraine, we have much less evidence for migraine and TMS. There are many small studies published on RTMS, R is repetitive TMS, to the vertex, to the prefrontal cortex, just like with depression. So there are many studies, as you see on the screen, that suggest that it may be effective. Again, placebo effect is very, very high. You have a machine, you have the equipment, you have high expectations, and it's very hard to do studies comparing it to sham treatment. This is another study published using TMS, repetitive TMS for post-traumatic headaches. And they actually looked at the difference between just doing it blindly. We know approximately where that area of the brain is, left frontal cortex, And that's what most psychiatrists do in the US. And in the US, luckily, for depression at least, it is covered by insurance. So this study looked at just doing by measuring the head, figuring out what the area is versus doing a specific area that's found by um, functional MRI testing. So this is a setup in our office. This is one of our patients who agreed to be on our social media feeds and the slides here in the lecture. So you see that's magnetic coil touching his head. And on the right, you see the machine that produces the magnetic stimulation. It's a thick coil because it gets very hot when you do a couple of thousand pulses, so the liquid cooled coil. On the left, you see a neuronavigation device. Most of patients, we will just stimulate the left frontal cortex, but also very often occipital cortex, because remember that device that you self-administer, single pulse TMS actually affects the occipital areas. But we also add motor cortex, and sometimes we have access to functional MRI. This is a research procedure. So we have access to a research procedure that tells us more precisely where the problem areas are. Major issue with this treatment, again, high cost. Equipment is expensive, time consuming. We have a technician running this. And functional MRI is also an expensive scan that's not covered by insurance. So we use left dorsolateral prefrontal cortex plus either motor cortex, as I mentioned, or bilateral occipital cortex. And this is the picture of fMRI. So unlike the regular MRIs that show the structure of the brain, here we can see color-coded areas that are either overactive or underactive. So they're connecting way too much or not enough. In case of depression, we know that left frontal cortex is not communicating sufficiently with the rest of the brain. And when you stimulate with TMS, that improves. And you can see those changes on this functional MRI. So dark areas are here two overactive, two underactive areas. So it's very interesting. In the research stage, it makes sense that results might be better. And Nolan Williams, whom I mentioned at Stanford, the accelerated protocol that they use for severely depressed patients is based on the findings of functional MRI, because for most people, left frontal cortex is the one that's at fault, but for some people, it's the right frontal or another area of the brain that is not functioning properly. So if you direct it more accurately, the results seem to be better. Again, we have many, many obstacles to overcome before this becomes widely available for migraine patients, mostly cost and also doing good controlled experiments. But that's very benign treatment without side effects. So that's before I finish, just Deidre mentioned my book. And the point of the book is a message of hope that there are 150 ways. Actually, second edition has 160 items on the list. So patients often come in and tell me that I've tried everything. I've been to 5 doctors. Well, I tell them you haven't tried even a third of things, because we have so many other things that you haven't tried that might work for you, because you never know what's involved. So that's the point of the book. If you think you've tried everything, there are many other things that you might want to consider, including the neurostimulation devices. So thank you for your attention.